Okay, we're going to begin the first lecture for NADN 2400. You will find the PowerPoint under Module 1, and you'll have 3 slides to the side, or the lines to the side where you can take additional notes, but you will have the actual PowerPoint. You will not be filling in words on the PowerPoint, but the notes that you will take will be from verbal, the verbal discussion. Okay, so let's go ahead and get started. The healthcare debate. Healthcare reform has been a controversy for over 100 years. So the quality of healthcare is less than ideal, the cost is more than expected, and also the access remains less than 100%. So that's always been the goal, is to get insurance for all. Most recent healthcare reform and its legislative outcomes is the Affordable Care Act. That also still has been continued. The debate has been continued, and most of what is causing the the debate is really revolves around the political talking points. It's about miscommunication and also fear of the people that is going to affect. You'll see also that there was a strategy later on. We'll talk about the strategy that was used to help to get healthcare reform passed. So learning from past mistakes. And one of those is to get the legislation pushed through quickly, which we definitely saw. What an enormous bill that came from the Affordable Care Act. And that was a huge document that I think a lot was not understood. It was moved through quickly. And so some of the debate is coming from the lack of understanding too. So looking at all sides of that. Oops. So what do nurses need to know? Healthcare, again, has been a long generated public debate. The Institute of Medicine, the IOM, or the Institute of Medicine, they recommend that all nurses should be full partners with physicians and other healthcare professionals. So nurses should know what the history, the scope, the cause, and also the potential solutions to issues. So why do we need to know this? So you would say definitely, why do I need to know that? Because healthcare policy is about the people, but it's also about the nurses as well. Healthcare policy is driven by cost, quality, and access. So it affects the decisions. When we talk about decisions that are made in healthcare policy, it affects our patients by which providers that they can see. So what provider can people see? It affects which clients can afford medications. It affects which clients can receive preventative or early diagnosis and treatment. So ultimately, it does affect life and death situations. So it's important for us to be advocates for our patients and help in those healthcare policies. Important reason also is how healthcare reform affects nurses. So waste and also workload is affected. So it determines, where nurses practice, what they are allowed to do. It also affects their ability to reimburse for the services that they provide. So if we look at eliminating waste in healthcare, it's definitely important for us to, as far as healthcare costs, eliminating waste is a good way to help to decrease healthcare cost. One of those, many hospitals and providers already use the value-based purchasing, which that is a method where you're able to obtain products and services at a lower price. It's also been used in private industry and also by the federal government for many years. They can negotiate lower prices and a better quality of service, and that also includes healthcare. It attempts to reduce inappropriate or ineffective care by identifying and rewarding providers who perform the best. So, for example, they use quality indicators. So the National Database of Nursing Quality Indicators, along with well-developed indicators as measuring tools, help to ensure that healthcare providers are held accountable for both the cost and also the quality of care. Nursing sensitive measures, it promotes optimal staffing and practice environment, which we know many nurses believe, of course, that the adverse events and the mortality rates are higher depending on the quality and also the number of staffing that we have. So it's important for our nurses to be part of the conversation that decides on data collection tools that determine that we have adequate and appropriate nurse staffing levels. So those nurse staffing levels, there's tools that they can use. One example is an acuity chart. So if you looked at your patients, the group of patients that you're caring for on a unit, it is very different to care for 10 patients who have a very high acuity versus taking care of 10 patients who have, are pretty much walkie-talkies. So looking at that acuity and determining what the number of staffing it is required to take care of those patients is really an important part to add into just saying that we have 30 patients and we're going to have 6 nurses. So everyone's going to have 5 or whatever the number may be for that specific unit. So acuity definitely makes a difference in staffing, the kind of care that we can provide, the safety, and also the outcomes. So when we look at the increase in the demands, what is causing the increase in demands? The nation's, some of those, one is when we look at the 65-year and older, so we talk about the baby boomers, that growth of those that are 65 years and older has rapidly grown since 2010. Those are the baby boomers. The other increase in demand is the availability of insurance. So for example, if the Affordable Care Act is fully implemented, there will be 32 million clients that would have insurance. And also that primary care, they would have the insurance and the primary care, and therefore more access would cause us to have an increase in the demand for healthcare providers. I'm not saying that's a bad thing, that but it tends to be that those who do not have any type of insurance do not seek out healthcare. So this increase in access will also increase the demand. So I'm not saying that's a bad thing. I'm saying that is our reality, as that we need increase in our primary care physicians or primary care providers, really. So how do we deal with that increase? Of course, we have that supply versus the demand. There's a shortage of primary care providers due to the increase in the need. So how are we going to deal with that? We can increase those providers. One is nurse practitioners. So nurse practitioners, they can safely provide about 80% of the care that's provided by family practice physicians without any kind of decrease in their quality or healthcare outcomes, and with an increase in the client satisfaction. The key here is that we use our nurse practitioners to the fullest capacity. So right now we still have some states who are still restricting of what nurse practitioners can do. So we need to be able to use these nurse practitioners to the fullest capacity. our states just are not in sync as to what you can do in every single state. So really they need to be used to the full extent of their education and also be fairly compensated for their work. RNs are the largest single group of healthcare providers in the United States. Nurses have not historically participated collectively in the full partnership with other players in the healthcare and determining healthcare policy. So we really need to, nurses need to educate themselves on the economic, the political, the ethical and moral, and also healthcare outcome issues that drive healthcare policy. Nurses must lead the informed opinions. They must lend their informed opinions and the conversations that during that process of finding solutions for healthcare problems. So again, nurses need to be heard as the client's advocates for their healthcare decisions. So looking at a little brief history of healthcare reform in the United States. Healthcare reform has been a political issue in the US since 1912. And then periodically it resurfaces again. So everybody wants good healthcare that is easily available and affordable, but really they just can't agree on how to accomplish it. So the debates, they revolve around some fundamental issues. In a democratic government, the role of government and individuals, regulation versus free market, rights versus privileges, federal versus state responsibility and control, and then there's the powerful and special interests. So always an issue. We've got large pharmaceutical companies, we've got insurance providers, physicians associations, they're all concerned about the financial outcome. So it impacts what can be done within healthcare reform. If finances weren't such the issue, and it definitely would help progress healthcare reform if we could see what is best for the whole versus only looking at those special interests and what they can gain or not gain from the decisions that are made. So presidents do get involved. In 1912, there was, Theodore Roosevelt, he became the first national political figure to call for some type of reform for national health coverage. FDR came along, and then conversation about the national health insurance retreated in a large part due to the opposition. So he found opposition with the American Medical Association. His work became eventually, the Social Security Act of 1935. But again, he did meet some controversy or meant some, resistance based on what the American Medical Association wanted. So FDR, he encouraged his aides to begin work on the national health insurance legislation, but he died before that bill was actually introduced. Harry Truman came along, and he pressed Congress to enact into laws a plan that was known as the Truman FDR plan, which was a single-payer public health care insurance plan. It was similar to Canadians' health care plan. However, powerful interest groups, special interest groups, and it actually inserted themselves, and therefore it ended up reducing that plan to just providing health coverage only for the elderly. John F. Kennedy, he had a vigorous advocacy of a plan to provide health benefits to the elderly. So that was the framework for the Medicare program, and he was assassinated prior to getting those laws enacted. Lyndon B. Johnson carried on. Though he was a successor to JFK, he presided over the passage of the Medicare-Medicaid Act in 1965, which was considered the most ambitious health insurance advance in the U.S. history until the Affordable Care Act was implemented. So lots of history here, everyone trying to make changes with healthcare reform, having these ideas, but not necessarily are they making progression based on, a lot of politics have affected what is allowed to be passed and what is not. So we're gaining in some respects, but not fully in others. So this continues to be a lot of controversy, a lot of debate, and we are making some progress, but it will continue to be something that will continue to need work. Richard Nixon, he was credited by many as the first president to attempt to hold down the rising cost of healthcare and also health insurance through healthcare reform. He signed into law, he was actually had the first manifestations of the managed care, so HMOs. That's who began with that information. He was the first president that believed that nationwide mandate requiring all citizens to have and pay for health insurance, which was the basis of what they used for the Affordable Care Act. And again, if you look into history, the Watergate scandal and the subsequent, his resignation of Nixon, that stopped all further progress of healthcare reform by his administration. So something is interrupting each time they make some progress, but anyway, that's how that has developed and how the maintenance, the health, the HMOs actually came into play. Jimmy Carter, he introduced health reform plan that it was similar to Nixon's. It included coverage for catastrophic illness or injury. He had employee mandates and a replacement plan for Medicare, Medicaid to cover all the elderly, the persons with disabilities, and also people living in poverty. This plan was united with the cost containment package that was directed at the hospital and the physician cost. That cost containment legislation, it did pass the Senate in 1979, but it was defeated in the House. Bill Clinton, he developed the Health Security Act of 1993. The initiative failed to yield any kind of significant health reform, and then Barack Obama came in 2009, 2017. He enacted the Affordable Care Act. Some changes that have happened since then, Donald Trump, he did repeal the mandate. He removed the penalty. His vision was a higher quality healthcare at a lower cost. Actions were taken to lower prescription drug prices and expand access to affordable coverage. Delivering hospital pricing at transparency. So we're supposed to have transparent hospital pricing, and it also allow the American people to have access to trusted doctors. So every healthcare reform seems to be something that is always continuously needing to be fixed. So what each administration does is they find something in which to attempt to make it better is the goal. So that's where we stand at this point with healthcare reform. Looking at some historical factors that are related to healthcare insurance. If we look way back, Germany was the first country to provide a form of national coverage, and that was under Bismarck in 1883. Seems to be a very long time ago. But if we look at Theodore Roosevelt and when he introduced the idea of national insurance coverage in the US in 1912, there was that strong anti-German sentiment in the US. So therefore, he wasn't able to progress his ideas at that time. So really looking nationwide, looking at other countries, it also impacts our ability to make changes in our healthcare system as well. In 1920s and 1930s, there was no government initiatives. There's no initiatives. So hospitals and physicians, they began to offer nonprofit private insurance plans. So what that did was it required that the individual only be treated by the physician in the hospital where they were, where he or she was actually insured. The Great Depression, there was a decline in the hospital occupancy. The American Hospital Association, they established that statewide Blue Cross insurance plan that provided hospital coverage at the choice of any hospital in the state. So very interesting that it's the Blue Cross or the Blue Shield was back as far as the Great Depression. The Blue Shield was then later added and it covered physicians' services. So again, the American Hospital Association established Blue Cross Blue Shield. So I find that interesting. In World War II, due to the wages and the price controls, employers, they discovered that they can legally use employer-paid health insurance to compete. So they didn't have employees, so to gain employees, they used that incentive or that benefit to be able to gain employees. After World War II, the unions then, they began to negotiate for health benefits in their contracts. And of course, this encouraged the growth of private for-profit commercial insurance. So interesting how it has evolved and who, using it to their benefit, but also to the benefit of the people as well. So to gain employees, providing those benefits. The original Blue Cross Blue Shield insurance, they set premiums by what was called the community ratings. So community ratings were set by the medical costs across the geographic location or the region, or even across the whole nation. The community ratings was unable to survive in the insurance market because of the experience ratings. So if we look at experience ratings, what they are is they're used to establish how much a specific individual or a group will have to spend on medical care. Okay, so that can be within a limited setting, such as industry. Ratings that are based on how much a person has already spent, what conditions are already present, and what risk factors a person has compared to what would be considered a normal expenditure. So what this does is it tailors health insurance policies to a specific group or an individual rather than looking at a geographic location. So they tend to have lower rates because the people that are using them tend to be healthier and younger. And they use that a competitive tool because they use that as a competitive tool because it does help to lower premiums for specific organizations. So for example, older Americans who tend to have more age-related illnesses were one of the groups that was the hardest hit by using the experience ratings. So again, kind of grouping together the younger, healthier people helps to get lower premiums. So therefore, it's an incentive for really for the people who use it to get better rates. 1945 Blue Cross Blue Shield, the providers outnumbered the commercial insurance providers 2-1. In 1955, commercial insurance providers outnumbered the Blues, so the Blue Cross Blue Shield. In In the late 1950s, there were fewer than 15% of people over the age of 55 had any type of insurance. So Medicare, Medicaid, legislation in 1965, that was first to offer coverage of persons that were over the age of 65. It also provided coverage for people with disabilities, children in poverty. So again, getting coverage, because we know that without coverage, healthcare, people do not seek healthcare because it's very expensive. In 1997, to help create, or CHIP actually was developed in 1997. That is the Children's Health Insurance Program. It was created to extend Medicaid coverage to many of those in the uninsured children and their parents. So again, there's usually some sort of a loophole where people don't quite make, like the Medicaid coverage, for example, they're right on the border. So they're not making enough. They're making just a little bit too much to get Medicaid, but then they're not making quite enough to be able to afford health insurance. They might be in a job. It's very difficult when they fall right on that border, because sometimes the job in which they have doesn't provide that, doesn't provide coverage for them. Maybe they don't give them enough hours or something of that nature. So they did extend the CHIP did extend coverage, Medicaid coverage, those that weren't getting insured but really needed it. So prevention really is our key. Prevention helps to decrease insurance costs. It is much cheaper to prevent an illness versus waiting until they have, a chronic illness that we have to address. It's much more expensive to do that. So anyway. So entry of the government into health insurance industries assisted those people that were left behind by their private insurance companies. It also created a guaranteed source of income to the healthcare industry. So it benefited them, okay? Healthcare costs increased as the government started to funnel money into those systems. Actually, what was happening is they were rewarding healthcare providers for increasing the number of services rather than for producing positive health outcomes. So this, in combination with not having any kind of restrictions on new and complicated technology, and that not having any kind of restrictions with that, also caused the health care costs to explode. George Bush signed into law an unfunded prescription drug benefit bill. This increased senior citizens' access to prescription medication through the Medicare Part D. So in essence, it was not funded. It was unfunded mandate that increased the cost of providing Medicare services, and included no additional cost savings measures. However, what it did was it did provide additional services for seniors. And if you look at, if you really look at retirement and Social Security, it's very difficult for people to live on Social Security. And what we have always found is that with our senior citizens, they would have to make choices. And those choices did not always mean that they chose to get their medications. They may choose, they're going to choose their food that they're going to have, and they might take their medications and split that in half. So maybe they're not being compliant with it. So as we assess our patients and we see that they're not taking their meds, why are they not taking their meds? Why, what is the root cause of them not taking their meds? Now we have the Medicare Part D to help with that. So, and we still find that there are patients who don't take their medications or they split their medications simply because they can't afford it. So it's still an issue, even though we've tried to make some improvements to help our senior citizens. So again, prevention is still the key. Prevention, keeps our patients, for example, insulin. So you got a diabetic, if they're not taking their medication, they're going to have further complications. So finding them coverage, nurses do a great job with assessing our patients. Using case managers is very helpful because we can get to root causes and of the issues. And then also our social workers, they do a fantastic job. So there are additional resources, even though we're attempting, there are additional resources that we can get for patients to help them with their compliance of their medication regimen. Oops. When we look at rising costs, it does spur reform. So, in an effort, this is what I was explaining earlier. So, since we've had this controversy for so many years, and over time they've decided to look at how they can change or make reform and be effective in implementing policies. So in an effort to avoid pitfalls of the previous attempts to bring about healthcare reform, a plan was devised. So what they do is to try to successfully pass healthcare reform, they want to make sure, and part of that plan is to have clear communication of the vision and the goals to the public. And you can see some of this once we get through all of these, you'll see how this plan has been implemented. Keeping all the stakeholders at the table. So who's going to be affected? Tasking the Congress to work out the details of the plan. Involve the states. Reduce partisanship. So that's where your conflict can come in. So if you can negotiate to where everybody agrees on both sides how this reform would affect both or would benefit both, really. So reducing that partisanship. Moving the legislation to a speedy completion. So pushing that through, you really kind of saw that with the Affordable Care Act. It was like one day it was very quick. That was a huge document that was pushed through pretty quickly. There was, I want to say, over 2,000 pages is what I remember seeing. So very large document that was, definitely moved through pretty quickly. Being politically forceful while moving the legislation forward. Selecting advisors and spokespersons who the public trusts. Limiting the scope of the reform legislation to a manageable size, and getting the congressional leadership on board early in the process. So in 2010, Barack Obama was successful in achieving most of the plan, except for managing that partisanship of the Congress. So again, it was signed into legislation, and again, the debate still continues, and reform still continues as we move forward. There are investigations in the mid 2000s revealed that some insurance companies, they carry out practices such as canceling or denying claims after a policy had been issued because the client's costly disease. They deny all claims for a period of time, and then they pay only for those that client actually challenges, the formal complaints or challenges that the client, submits. And they also fail to pay claims for non-existent pre-existing conditions. So let that sink in there. So preventing cancellation and policies due to pre-existing conditions, that was one of the key purposes of the Affordable Care Act. So, definitely a very positive thing that came out of that we cannot penalize people for pre-existing conditions. What would they do? So the insurance company, if they stand to gain, right, by not covering those with pre-existing conditions. So using that's a disadvantage to our patients, and that's not giving them the coverage that they need, nor would it give them the continued care that they need to prevent furthering their chronic disease, for example. So what happens when if you have a pre-existing condition and your insurance company decides they're not going to cover that health care is picked up somewhere, or that care is picked up somewhere. It might not be picked up by your insurance company, but it will be picked up through government sources is what actually will happen. So another good thing that came from the Affordable Care Act was being able to stay on your parents' insurance until 26. That age group, the preventable diseases that we were seeing in that age group up to 26. So, what's happening when you're 26 years of age? People get out of high school, and they either go into the job market or they go to college. So in both routes, you may not have access to a job that pays well enough to pay for insurance, or it may not have, jobs that are provided at that stage do not give you the benefit of having health care. So what we saw too was that those that are less than 26, typically it was, they weren't being covered, so they weren't getting preventative care. And you would even see in our local free clinics that we had very young people, 22, 23, who had very high blood pressure, putting them at risk for stroke. So they wouldn't seek out healthcare. They were coming to the free clinic. Thank goodness we had that option for them to be able to get them the medication that they need to then prevent further chronic disease. So it's really kind of a snowball effect. If we don't care for people in the long run, it will be paid for one way or the other. So prevention, of course, cannot stress that enough. Prevention is much less expensive than it is for waiting on those chronic diseases to occur. So prevention is definitely the key. Let's protect our people. Let's get them that medication that they need so they can not have chronic disease and end up on disability. So it all just kind of snowballs if we don't take care of our population. There are 4 driving factors that delineate the need for healthcare reform. There's economic, there's societal, there's health outcomes, and also the ethical moral. I'm going to talk about each of those. So when we look at the economic issues, so this is pretty interesting. When we look at the US in comparison to other countries, it's very interesting. So there's an organization for economic Cooperation and Development. It's an international organization that compiles information. It analyzes the information in the international healthcare data. So that organization represents 35 industrialized countries. So we're going to look at some of that information here. So really the US is spending 2.5 times more than the average of all of these 35 industrialized countries. But the life expectancy in the US, and it's below the average of those 35 countries. The US healthcare cost per person is twice as much as those in France. So sometimes though, if we look at the statistics, it also can be a little bit misleading. So the figures can be misleading because healthcare expenditures include paying for treatment that's not always available in other countries. Cost of research that is funded in the US is greater in greater amounts, and the cost of self-medication and treatment. So nevertheless, though, the end result is that the cost versus the outcomes is still disproportionate. Health care costs have grown much more rapidly than other sectors of the economy, and the healthcare share of the national economy has increased disproportionately. So if we look at 1970, the total healthcare costs in the US were approximately $75 billion, or $356 per person. There was an increase in spending to 9,892 persons in the healthcare in 2017, and 3.2 trillion for total healthcare cost. The share of the overall US economy has risen from 7.2 in 1970 to 17.2. Okay, so it's showing a slowed trend from 2017 to the present, and it's going to show, and what it does, so it's shown some decrease, but it does show the projections of that by 2025, the healthcare share of the gross national product will be close to 20%. So again, remember what's causing our increase in our increase in our demand, which is the aging baby boomers, and also elimination of those tax related provisions, such as the individual mandate and the Affordable Care Act. Societal issues. Societal issues, issues other than economics and politics can interfere with the access to healthcare and quality of care. So the health status can also be affected in part by your social, your economic conditions, and what kind of resources or support systems do we have in our schools, in our homes, in our neighborhoods. So you will see healthcare going into our school systems, for example, looking at dental care, for example. Sometimes in pediatrics, for example, our children may never go to a healthcare provider. So their only access to a healthcare provider is in the school system. So the school nurse may be, an advocate for that patient or that student at that point. Although there's rising healthcare costs that cause many people to have difficulty, they have difficulty paying their medical bills, and they put off the need for healthcare because of the cost. Those percentages are noticeably higher, so they're not getting care. The percentages are higher of people not getting care And those that are lower economics, have a lower income, they, and with those that don't have insurance, both public and also private. So we know, again, that those who do not have insurance tend to not get health care, do not have any kind of health care. So again, that's where we've reached out in different neighborhoods. That's how we ended up with the free clinic. So we had the free clinic in Marietta that provided for those who did not have any kind of insurance coverage. And it was continuously, those appointments were continuously full. So that tells you what the need was for our, and that was here within the last few years. So even with the Affordable Care Act in place, people were still did not have insurance. I think some of the issue too comes with high deductibles. So you may have insurance, yes, but are we looking at the userability of that insurance? You know, can that person afford the deductibles? So even if you had insurance and can't afford it, so you may still not, there may be other reasons socially or as an economic issue that you do not seek health care, even if you are insured. So in 2010, there was a study by the Kaiser Family Foundation. It showed that only 10 to 12% of the non-elderly adult population with insurance or Medicare had no regular coverage. The rate among the uninsured was 55%. It also showed that the non-elderly adult without insurance was almost 3 times as likely to forgo needed health care and over 6 times more likely to not have care than those that had insurance. When we look at children, it too shows that the data ensures that, and the data on the insured and the uninsured children is definitely very revealing. So children with no insurance they had over 7 times more likely to have no regular care than those with Medicaid, and almost 10 times more likely to have no regular care than those with private insurance. So again, the bottom line here is that the uninsured, they're going to avoid seeking health care. Also, those who have high deductibles will also avoid health care. So they know they can't pay the bill, and so therefore they just do not seek the care that they need early enough. Pervasive disparity, the socioeconomic conditions that created traditional health disparities are further causing an increase in the loss of health insurance. The person with income below double the poverty level is 3 times more likely to be without health insurance within a year than are those that are 4 times the poverty level. So healthcare disparities among minority groups undermine the healthcare outcomes of all aspects of care. It includes that it undermines the healthcare outcomes. That includes access to care, including quality of care, and also the efficiency of delivery of care. So again, access, quality, and efficiency. Cost shifting. Healthcare costs increase for everyone when people without insurance receive no preventative care. So basically, there's no preventative care that leads to no early treatment or interventions, which is going to cause, it's going to lead to those chronic health problems and also late stage serious diseases that end up costing, it costs more money to be able to go to the hospital setting rather than the preventative care that we can get from our doctor's offices and from our clinics. So when we look at one study, the uninsured people received 116 billion worth of care from hospitals, doctors, and other providers. Those that lack insurance only paid about 1/3, so 37% of the total cost of their care they received. Approximately 42.7 billion went unpaid and constituted that uncompensated care, and that decreased about 35 billion under the ACA. But 35 billion of uncompensated care is still a huge amount of money. So basically the way that cost shifting is done now with insurance pay, you know, those that have insurance, they pay about $1,100 per year in increased insurance premiums to cover the uninsured or the uncompensated care. So the cost of the people without health insurance falls on taxpayers for the government supported programs or private insurers in the form of that increase in taxes and premiums, which they refer to as the hidden healthcare tax. So again, I say, you know, insuring and prevention is less expensive than the uncompensated care. Eventually, somebody is paying for it, whether you have insurance or you don't have insurance. So that prevention of the part of the ACA where you cannot penalize somebody for a pre-existing condition is very positive, you know, because the insurance companies, of course, they don't want to take responsibility for that. So if they don't take responsibility, then eventually that just rolls downhill and the taxpayers will end up paying it through that hidden healthcare tax. So it gets paid eventually somehow. Health outcomes issues. So the US pays more for private pay and out-of-pocket costs for healthcare, but they don't always have the best outcomes. Societal issues such as drug use, obesity, poor lifestyle choices, and violence, they all play a significant role. However, the single major differentiating factor between the other developed countries and the US is access to healthcare. So we have access to care. The US does lag in some key measures. So if we look at how we compare to those other countries and looking at the ranking, it's kind of telltaling, but there's a little more that you have to look at, I think, than just the numbers as well. So mortality rates, we rank 30th out of 37 wealthy countries. Mortality rates from preventable diseases and illnesses, we rank 19 out of 37. Long-term kidney transplant failure was the highest in the US. Number of beds, hospital beds per 1,000 citizens, we rank 23 out of 37. Infant mortality, we rank 19th out of 37. And the US ranks #1 in healthcare spending per person at $9,892, but we rank 35th in healthcare quality. So they're saying we spend a lot more money, but we don't have really good outcomes. However, Switzerland with socialized medicine spends $7,919 per person and is ranked #1 in quality of healthcare. But, you know, we always have to think, what about that question that was posed before, where it stated that the one single major differentiating factor between other developed countries and the US is that we have access. So we have more access. So the more access you have, are we going to spend more money? So is our, we already established that if you have access to healthcare and insurance, that we are more likely to get healthcare. So is that part of the equation? So what about the access part? So yes, we spend more, but what about the access from one versus the other? So it's a very interesting conversation to have about the healthcare debate there. So higher mortality rates. There are fewer physicians per capita than in most other developed countries. So, there's 2.6 physicians per 1,000 in the US, whereas other countries, they have 3.44%. This is where, again, we know that we have a shortage, and that's going to increase. That shortage is going to increase, but we have taken measures to start to add additional primary care providers. So the advanced practice RNs, so APRNs increased by 51% between 2007 and 2018. We also look at the life expectancy. There was an increase by 12% between 1960 to 2014, but it dropped in the last, it dropped in the 2 years between, it dropped by 2 years between 2015 and 2017. What occurred there was the opioid overdoses and the disparity between ethnic groups. The mortality rate among children 1 to 19 is the highest in the US. So, in comparison to the 37 wealthiest countries. So when we look at that 1 to 19 years of age, the World Health Organization, they identify that males are higher than females as far as the mortality rate. And what is interesting is, this was the World Health Organization up until 2016. So I'd be interested to see, when they do their next, usually whenever they do their next, survey of information, what would be the highest? Because for males, it was road injury, interpersonal violence, and self-harm were the top three. That was between 15 and 19-year-olds. Were the females, which was interesting here too, is that maternal conditions and self-harm were the highest for females aged 15 to 19. When you look at males from the age of 10 to 14, it was road injury and drowning, and 10 to 14 in females was HIV and AIDS, which I find very alarming. HIV and AIDS and road injury. So just some of the current statistics and, what is causing our mortality rate to be so high. So I would anticipate, of course, that one of the biggest things at this point, you see a lot of suicides. So it'll be interesting to see their next bit of information. The World Health Organization, the American Medical Association Code of Ethics, the American Nurses Association Code of Ethics, and many of the social and religious groups support the idea that access to healthcare is a basic human right. Almost everyone agrees that healthcare should not be available. It should be available to everyone and should not cause, the risk of bankruptcy. The question is, the ethical issue focuses on the most equitable way. So to make that that possible. So how do we make healthcare equitable? So there's many questions that are asked, and nurses need to understand these issues. Should those who have more economic advantages bear the bulk of the cost? Should those who choose a less risky lifestyle pay less than those who do not? Should people pay for services they do not need because others need them? And can the government force people to have health care coverage and to get health care? And who gets to determine the appropriate treatments and how much should they cost? So this is where we're going to stop for this week. Next week, we'll talk more about the moral and ethical issues. Also, I will be posting a discussion question based on the Affordable Care Act, and that will be considered part of your attendance. So if you're not listening to the recordings, we'll know you didn't attend because you'll know that that assignment is due by our next class period. So it won't be due on Mondays, but it will be due the following week. So just as a reminder, the content that I'm giving you now is not due until your pediatric class on Mondays. So my goal, again, is to record lectures and to have those available to you by Friday. So that gives you ample time for you to do it at your convenience. And it keeps you from having 2-hour lecture for NADN 2400 and then your pediatric 2.5-hour pediatric lecture on Mondays. So this just gives you a chance to break up the information and to absorb that in a little smaller increments. Mondays, remember, Mondays are optional question and answer, so please do not hesitate to attend. It will start at the regular class period time, starting at 10 a.m. I will open up that that Zoom meeting, so all of you are welcome to come. Please come with your questions. I want to make sure that you are clear on what is expected of you this semester and help you to be successful to get through the program. So look forward to seeing you in clinical and also seeing you on Zoom.